Morning, good afternoon, everybody. Thank you for joining us for this Q&A session. We have the wonderful Dr. Bob Gish, who's in the States, who's a very old friend of the foundation, a very dear friend of mine and my dog. That's another story. And I'm Collette. I'm retired, and I'm going to be doing the questions this afternoon. We hopefully will keep them interesting. And please do bear in mind, we cannot compromise the foundation, we cannot compromise our doctors by answering questions that would really tantamount to a private consultation. So all the questions that will be asked will be responded to in general terms, but you still will get a lot of knowledge, I'm sure. You okay with that, Bob?
You are the leader. I'm here to help.
I kind of like this kind of chat. Right, Bob, I know you've seen the questions. I've kind of rewritten them and just, edited them a bit. And there's a couple where I can't actually pronounce one or two of the words. Would you be a gentleman and help me out when we come across that?
Well, but that means I need to pull up the worksheet. So let me look for that. No problem. Had it up yesterday. Okay.
Right, everybody, here we go. If you're in this event, you can put some questions in the chat box, and we've got quite a lot to get through, but I'm determined we're going to do them all. Okay, Bob, is there a connection testing positive for AMA-M2 antibodies and positive antiphospholipid antibodies and ANCA antibodies, but not experiencing a clotting event?
Oh my gosh, that is a complex question. It's very good. So, big picture, there are many different types of autoimmune diseases in humans, and there are markers of different autoimmune diseases in humans. So we usually use these antibody tests to help identify what type of autoimmune problem is occurring in combination with examining the patient and taking a medical history. So the AMA-M2 antibody is very specific for primary biliary cholangitis, but it can be positive in overlap syndromes with other diseases. People who have autoimmune conditions can have 2, 3, 4, 5 different parts of their body involved, different organs involved. The antiphospholipid antibody is commonly seen in lupus syndrome, but it can be seen in a variety of other types of autoimmune disease. And it does have an association with clotting, blood clotting, excess clotting, but it doesn't mean a person will clot. It just says there's a risk. ANCA, anti-neutrophil cytoplasmic antibody, is associated with vasculitis, and it's associated with primary sclerosing cholangitis. So these all overlap. They can be associated with different conditions. You need a good provider, good medical history, good physical exam, and then decide if these are significant on an individual basis.
It's very complex, isn't it? And I hope that answered the person's question. I don't think we should go any deeper than that. Okay, so the next question, and there's two parts to it. If a patient has portal hypertension, can this be linked to splenomegaly and varices? Could this also be polyps? Is it possible for polyps to be mistaken for varices or vice versa? Now that's quite a question, and I know what you're going to say to that, but it's an important question to ask, isn't it?
Okay, I see all three of these. Let's walk through this piece by piece. What does the word portal hypertension mean? Has that been explained, Collette, at any of your previous meetings?
Yes, people who have portal hypertension, but yes, people know what it means. And for those that don't, probably newly diagnosed, so I don't like to go into full details. But
here's something good, though, that everybody should remember. Everybody with chronic liver disease of any type, including PBC, should have a full abdominal ultrasound. And on that ultrasound, the radiologist should measure the spleen and portal vein. Portal vein is the vein that feeds the liver. And if the spleen is bigger than 12 centimeters, that's splenomegaly. portal vein bigger than 12 millimeters, that's portal hypertension. You put those two together and you would say, oh, this person's got, moderate to advanced cirrhosis to have those. And you would think about doing an endoscopy, putting people on a medicine called carvedilol to decrease the pressure. Have you talked about carvedilol before?
Not that particular medication. I haven't, but one of the team may well have. But they use other medicines here in this country, and I'm sure they do elsewhere.
Carvedilol is really global, and it's the best medicine to lower the pressure, portal hypertension. Now, this question about polyps, they're indirectly related to portal hypertension, but not directly. Polyps often mean inflammation in the lining of the stomach. They could have Helicobacter pylori infection, a bacterial infection. Sometimes they're just in response to chronic inflammation. And a good endoscopist could easily tell the difference between a polyp and a varix. There is a risk. They could be an overlap, or a polyp could have a varix in the middle of it. And then, of course, you biopsy the polyp, the person could bleed because the varix is underneath. We do have special tools to determine if it's a polyp or a varix or a mixture with a tool called an endoscopic ultrasound. And that's the most sensitive way to pick up abnormal blood vessels in the esophagus, stomach, and duodenum. So finally, splenomegaly, typical for primary biliary cholangitis with cirrhosis. That's the most important message here. Portal hypertension, endoscopy, carvedilol. Those are some of the code words a person would talk to their provider about.
Okay. Thank you for that. So propranolol, I hear people have in this country as well for varices. So the next question, since taking Urso for over a year, all liver tests have been fine. Great. Now there's a sudden ALP, AST and ALT are all out of range. I've not spoken with the consultant yet. This person's had a lot of stress. They take D-mannose, which is a supplement to help UTIs. Is this normal? I do have to say to this person that you really do need to speak to your own consultant, because it's not just these liver tests, your enzymes and your function. There's a whole lot of things he knows about you that we won't know in a small question like this, which we are happy to answer. But you really need to speak to your own consultant, because they know the whole picture. We're just getting a small segment.
But Collette, we have some good teaching points here. And the first one is Urso needs to be at full dose. That's 15 milligrams per kilogram per day. And it's very nice. I
wonder, Bob, sorry to interrupt, and I did wonder, sometimes when people take Urso, they gain weight. And we know this. They never used to say that in the beginning. And if you are gaining weight, keep an eye on your weight, because you'll have to increase your Urso according to your weight.
Well, I'll say one thing. Urso doesn't make them gain weight. They're happy because they're on Urso and they eat more.
Well, the jury's out on that one, Bob. But either way, please do keep a hold of keep an eye on your weight, weigh yourself. And we have a chart in PBC, and it's in metric, it's every possible in Universal. You can check your own weight and how much you need to take, and let your doctor know as well.
But Collette, the reason that's important is with weight gain, you can develop fatty liver. And right now, 25% of my PBC patients have fatty liver. And then what do I do to figure out, is it mostly fat? Is it active PBC? I'm doing a lot more liver biopsies. I'm asking for liver biopsies very frequently now to figure out what is the dominant condition, what's causing this to go up.
Wow, that's sad to hear, actually. I'm just going to show, this is a chart. That's our chart. You can pick that up from our website, and that's in Imperial and in metric. So, and check your weight. But I'm sorry to hear that, Bob. So there's a wee message there to people, if you are gaining weight, it can affect your liver alongside your PBC. So this person's PBC 3 years and response to Urso, been feeling unwell. had an ultrasound to check for gallstones, and the LFTs are normal, which is great. If gallstones confirmed and I need a gallbladder removed, what would this do to the PBC? What other tests prior to surgery? Advice welcome.
All right, so let's see. I think in this situation, the gallstones could or could not be causing symptoms. Usually gallstones cause liver pain, right upper abdominal pain. It's colicky, it kind of goes up and down. So I would definitely want to know more details about feeling unwell. It's a good general comment.
Yeah.
In this case, the LFT term is wrong. What they really mean is their liver enzymes.
Enzymes, yes.
And LFTs, we're not using that word anymore. We use it, we say liver enzymes or liver function. And if we say liver function, we mean bilirubin, albumin, and INR, which is a clotting test. So we no longer group everything together because everybody gets confused. So the other thing is when people have PBC, they can have other autoimmune conditions. So every PBC patient needs to be checked for sprue. It's a blood test and maybe an endoscopy. Also need to be checked for active thyroid disease. So every PBC patient I see, I check a TSH twice a year. The TSH is off, up or down, and I do a more thorough workup.
Yeah.
So back to gallstones, have a dialogue with your provider, maybe a surgeon, although you know what surgeons, if they have a hammer, everything's a nail. So be cautious when you talk to a surgeon because they love to take gallbladders.
Is it worth saying, Bob, that the treatment for gallstones years ago to try and dissolve them was ursodeoxycholic acid, which is why, you know, those and such as those tipped across it for PBC. So some gallstones are treatable, but I think it takes quite a while. But it's quite interesting that we benefited from that. But really, so this person is asking about if they do have surgery. I mean, it's a relatively straightforward operation, isn't it, Bob?
Oh, yes, and it's done laparoscopically. Usually it's an hour. Sometimes people are home the same day or the next day.
Yeah.
That's correct.
Which is great. Okay, so this lady's been taking Urso 875 milligrams a day for a year. Bloods every 3 months. ALP was 385 and GGT close to 300. They were steadily going down at 144, 230. Yesterday they're up 210 and 250. What could cause this spike? And I would say, you know, I'm always reminded by hepatologists that they don't look at one lot of blood tests, they look at trends across the period.
Correct.
You agree with that, Bob?
Yeah, so trends are important. Don't act just on one. But I'm going to ask this person to make sure they're not drinking any alcohol. When I see a GGT higher than an alkaline phosphatase, I'm worried about alcohol exposure. I'm definitely worried about fatty liver. I would want to go into detail about BMI, body mass index, of course, weight, lipids, hypertension, diabetes, prediabetes. So there's a test called the hemoglobin A1C. But one thing we need to highlight is this overlap syndrome. And overlap meaning you can have autoimmune hepatitis combined with PBC. But in that case, the AST and ALT are elevated higher than the ALK phos and GGT or moving up in parallel. So when individuals are describing their liver panel, they should always include all 4 liver enzymes and talk about the trend in all 4 liver enzymes. So that's important. But this is really the perfect time to bring up second-line therapy. We have 3 very good second-line medications. We have OCA, obeticholic acid, Ocaliva. Number 2, we have elafibranor that has the brand name Iqirvo. And we have cilalopar. Cilalopar is the most recent entry on the market for our patients. That's called Livdelzi. So the goal in PBC is to have a normal alkaline phosphatase and normal GGT. And we as providers are constantly thinking about how do we get there. In Europe, there's very broad use of a medicine called bezafibrate, right, Collette? Is that discussed?
Bezafibrate, yeah.
So I'm sorry, we pronounce it Beza, but okay, you're teaching me. Bezafibrate is not available in the US. It's off,
Oh.
it's off label. There's
Mhm.
no large prospective study. It's not licensed for PBC, and it has a variety of side effects: bone marrow, gastric, liver, kidney. So 25% of people on Beza have to stop because of side effects. So it's strange that providers use this drug so liberally off label, and it was never approved because, quote, it's cheap.
It's cheaper. Absolutely. It's pennies.
Well, if I was going to go out and just say, well, I got a cheap car, it's but
Yeah.
it's going to break down every 3 days, and there's no warranty on it, and the bumper is going to fall off. I only use licensed, approved medicines for second line therapy. I do not use Beza. I do not use fenofibrate. So I think the evidence-based academics using this off-label, no phase 3 studies because it's cheap
Yeah.
is inappropriate. But that's my strong opinion.
Well, I'm pleased to hear it. I'm pleased to hear it. So anybody who's listening to this, who in this country who've been asked to take bezafibrate, you can go back to your doctor and question it and tell them what you've heard here today. Not fair, Bob? All right. So somebody's been reading online that they've been researching into the antidepressant mirtazapine having a positive effect on the ALP and PBC. Do you have any knowledge of that, though?
Zero. No idea.
Oh, okay. That was easy. Right. We're going on to the ALP again. If ALP is elevated around the 200 range, and it's been since starting her, so would doctors prescribe, well, allowed for before OCA? Before OCA. Also, is it available in rural Canada? I don't really know what's available in Canada, Bob, would you?
I don't. I think OCA is.
I just thought it was just Europe where there was a problem with OCA, wasn't there?
Well, let's go over OCA for a moment. It's been available, I think, since 2016.
Mm-hmm.
We have over 50,000 patient years of exposure or use of OCA.
Mm-hmm.
The problem with OCA is we don't use it in patients with portal hypertension. And that portal hypertension is a surrogate or a model to explain liver metabolism that's off, because OCA in these patients can accumulate in the blood and cause liver damage. So OCA is, in my opinion, very effective and very safe in people who don't have portal hypertension, and it should be considered. Elafibranor and cilalopar are more recent medications. I don't know exactly where they're approved right now, but those are the three drugs that we consider. So, and then people ask me every day, why or how do I choose which of these three drugs to use? And what I tell them is cilalopar is really good at reducing itch. So if someone's having terrible itch, cilalopar would be a great choice. If they have moderate itch, elafibranor would be a good choice. If they have minimal or no itch, OCA would be a good choice, as long as they don't have portal hypertension. Got some had asthma allergies this week.
Oh, sorry.
So that's the story. And the simple answer to is that if you have fibrosis 2 or higher, then you work with your provider to get that alkaline phosphatase normal.
Yeah. It's quite interesting, just what you were saying there about the itch and what have you, and which drug you would offer depending on symptoms. That's the one thing that I've always found fascinating is the symptoms of PBC, and you know what the two main ones are. But there's some people who never, ever, ever itch. And there's other people, as you know, end up having a transplant because their quality of life is so intolerable because of the itch. It's quite remarkable, isn't it?
Yeah, I heard of that too, and that happened with one of my patients many years ago. But I have an itch sheet that's on my website, and I would say I can get the itch under control, very much under control,
All right.
in 95% of patients. But the problem is you end up stacking 2 or 3 itch drugs for one person, and their life gets very complicated. But Collette, can I ask you a question?
Yeah.
How many of your people who subscribe to your channel have talked about using primrose oil?
I've heard it from time to time. So do you mean primrose oil as in a capsule?
Capsule to eat it. 2 grams twice a day is what I tell every patient to go on.
Okay.
And it usually reduces itching 30 to 50%. And it's
Wonderful.
homeopathic. It's healthy. It comes from a flower. It's pretty fun to talk about it, but it works.
Cheryl's in the background. I know Cheryl will be very keen to take note of that, because we produce lists of things that may help, sometimes registered medication, some just other people's tips and what have you. Because I know a few people have said, for example, what makes their itch worse is eating chocolate. So we have sheets of paper and what we hear, and we will definitely put primrose oil down. I find the chocolate one, I don't eat chocolate. I've never eaten chocolate in my life. I can't stand stuff, but interesting that when people give up chocolate, their itch improves. But primrose oil is on the list as I speak. I'm sure Cheryl will do that for us, okay? So my question, this person says, about the clinical care of recurrent PBC in transplant patients and the results of OCA over URSO and antiviral drugs showing any promise. Before I let Bob answer that, I would like to say to anybody out there that if you are taking URSO and you're given a second-line therapy like OCA, you keep taking your URSO. It's not either or. You must stay on URSO. I still do take helpline calls, and I hear this more often than I care to hear it. And I would reiterate to people, you stay on your URSO. Anyway, so post-transplant, Bob.
Well, we know 20 to 30% of people with PBC will develop recurrent disease. And we believe strongly that URSO being started soon after transplant blunts that disease from happening, from being aggressive, from progression. So it happens, but every patient is different. You can't say, oh, PBC is bad after transplant. Some people, nothing happens. Some people, it's very mild. A small subset of people, it can be rapidly progressive. So anybody who has a transplant, thinking about a transplant, should be on URSO after transplant, of course, and then have their provider track their trajectory of their fibrosis. And that can be done non-invasively. Doesn't require a biopsy every year. They can do that with the FibroScan-like device, which there's 5 competitors now.
That's great. So we're not big on biopsies over here. And I was told relatively recently that I was the first person in the UK to be diagnosed with PBC without a biopsy. I've had PBC 30 years and I still haven't had a biopsy.
Important. After transplant, a lot of transplant surgeons especially, say the liver tests are going up, it's got to be rejection. And then they just start throwing medicines at the patient, driving things. In a person with a liver transplant, rising liver enzymes, they need a liver biopsy to figure out what's going on.
Okay. Very specialized, highly specialized. So this person says, a couple of months ago, LFD is fine, but alpha fetoprotein levels of 22 in 5 days, and then later to 20.6. And this person doesn't really understand why that's happening. They go on to say they had phase 4, but it didn't catch the right lobes, so had been waiting for an MRI for some weeks. And they didn't want to take, I think it's glandolium, which is requested for the MRI. They didn't want to take it. That is their choice, of course. So they've had a chat with a hepatologist, but the implication, the AFP, I don't fully, the alpha phenoprotein levels, I don't quite understand it, Bob. I'm sure you understand it far better than I.
AFP is a blood test that indicates a risk of liver cancer. It's not a diagnostic test for liver cancer. So it's a risk test. I use it in combination with 2 other risk tests. One's called AFPL3, and the third one is called DCP. We make this panel, we put it together, we calculate a special score, and it says cancer risk in the next 5 years. So it's a risk marker. CT scan missed the right lobe. I don't know why. An MR scan with gadolinium is the standard of care, and this person needs a multi-phase MRI with gadolinium, and that is the state of the art. You can have an MRI without contrast, but it will miss a lot of early tumors. So anytime there's elevated AFP, especially repeat, time for an MRI with contrast and work with your hepatologist. And just a reminder, LFTs, that term's out of date. We say liver enzymes or liver function, depending on what we're talking about.
So this substance, is this essentially putting dye into the body to see the contrast, to give them a better picture?
Collette, no one likes the word dye, right?
I consider myself told.
We want to avoid that.
Okay.
We use the word contrast.
Okay.
CT or MRI, or even ultrasound. There's a contrast ultrasound. I just had one of my patients had one of those last week. Very special test.
So is something injected into the body, or formula injected into the body to create the contrast?
Exactly.
I will mind my tongue in future. So we're back on ALP again. It was on a downward trend, this person says, was 144 in November. And May, the ALP was 211 and then 225. Is this person a partial responder, or is it something to do with back and hip pain?
Oh, well, let's see. This is the same story we've had today a couple of times, where the alk phos goes down, goes up.
Yeah.
So we want to make sure people aren't drinking alcohol. We want to make sure they're not developing fatty liver. But this is also a case where it's time to discuss second line therapy. And I really want to emphasize scanning people, determining fibrosis level every 12 months. And that would be a combination of imaging, like FibroScan, and a blood test like FIB4, or another test called ELF, ELF. Have you discussed ELF, Collette?
Yeah, the ELF test is very expensive. It's what I happen to have at my clinic. And they tell me it's expensive, but I feel I'm worth it. It's about £100 a go. But yes, there's and I think it's used in favour of the fibros. You know, when people are getting fibroscans, our hospital just does the ELF test.
Yeah. It's a blood test. It's a combination of 3 biomarkers, what we call proteins, I guess, that determine collagen turnover, scar tissue building and dissolving. So ELF test in the US has an FDA approval for staging and prognosis. So staging means this is where you are today, and prognosis says this is where you'll be in 5 years. So ELF test is a very useful test, and I encourage people to get that. Obviously, if you have to pay cash out of pocket, that's a challenge, but it's very good.
Well, somebody mentioned the ELF test to me the other day, and they were told, and this is the kind of, it was actually very nice to hear this. So this person was told they had less than a 4% of a serious incident in 15 years. And I thought, what a lovely thing to have with you when you leave the clinic. You know, I was very impressed by that.
Very reassuring.
Yeah, very. And just while you've mentioned fatty liver a couple of times now, Bob, can I turn to that for a second? When people talk to me in the helpline, they invariably, when they're newly diagnosed, they do talk about diet, you know, and about what any do's and don'ts. And I do say to people, you know, keep your water intake up, you know, not just 1 glass of water a day. I don't know if you're in pints and litres, but a good couple of litres of water a day. But I also feel that one of the worst things ever made or produced or put into food is sugar. And I would challenge anybody who takes a lot of sugar, and there's hidden sugar in food, and there's hidden sugar in most things. But if you're one of these people that cook for yourself, if you feel unwell, try giving up sugar. don't eat the biscuits, don't eat the cakes, but look for the hidden sugars and things and saccharins and sweetex and all the rest of it, because I don't think it's good for anybody, let alone people with PBC. What was your thoughts, Bob?
Sugar is a poison. I don't add sugar to anything unless I'm cooking, and I might add a half a teaspoon to make a soup or a curry or something. That a diet free of simple sugars is a fantastic way to clean up your body, clean up your metabolism. Excellent point.
Yeah, no, I'm really hot on that. So now the next one's a very interesting one, Bob. Can some tolerate different types of urso? This Grindex, this Falk. I want to make a wee point here. I was doing a conference with James Newberger many years ago, and people brought up the different types of urso. And there was a chemist in our audience, and he said it's not the urso itself, because it's all, whoever makes it's the same. It can be the coating or the capsule that has the different components. And so therefore it may well be the coating that you could be allergic to or have a reaction to. What do you feel about that, Bob? I thought that was a really good point.
It's a good point. And if you're not tolerating one type of urso, try to get another. I think in the US we have 4 different brands. I've never heard of Grindex or Grindex.
No, I haven't. Do you have Falk?
Urso Falk's been around the longest. That was Dr. Falk. He's a German scientist who developed his own pharmaceutical company, and that was one of his first products.
We met, and last year his daughter and granddaughter now run the company, and his granddaughter came over from Germany. She came to one of the PBC Foundation summits, and she's very tall. She's 6 feet tall. And they filmed us having a walk and a talk in the garden, and I was able to tell how wonderful he had been to me, to us, and starting the foundation all those years ago. It's a lovely story.
Incredible.
Good guys.
Very interesting.
So try a different. There's also a suspension. There's a liquid form. It's given mostly to children, but they will prescribe it for you. It's vile. I've tasted it, but it's there if you can't tolerate anything else. So the next question, PBC, 22 years responder, recently a facial rash, something with rosacea. Is there a link?
There is a link of PBC with different types of autoimmune conditions, different types of rashes, skin conditions. If there is a link or there's a direct link, you can't treat the PBC to make the skin better. You'll just need to see a dermatologist to treat the rosacea. So that's what I would do. Linkage or no linkage, the skin condition needs to be treated.
Is that an autoimmune condition, Bob?
Yes, it's in the family.
Yeah, can we just make a point about autoimmune conditions as well? Because people ask me quite a lot, is PBC hereditary? So go on.
Yes. So the story is anybody with PBC needs to be monitored for thyroid disease. That's autoimmune. Sprue, that's autoimmune. Skin rashes, that's autoimmune. They can have joint arthritis, pains, that's autoimmune. And then the family gets much bigger. You could have psoriasis, you could have lupus. There's a variety of other autoimmune conditions that attack the lung or the pancreas. So the provider and patient have to be very aware. Any new symptoms, any new signs, look broadly.
Yeah, no, that's a very good point. If anybody has new symptoms or something different, don't just assume it's PBC, do get it checked out. But going back to people quite often ask me a lot, is it hereditary PBC? And the answer is no. But what I do say to people, for example, Bob, I'm one of 7 children. I'm the only one that has PBC, but my brothers and sisters have thyroid disease and one's celiac and what have you. So quite often, where there's somebody with PBC, there's other autoimmune sitting in the family.
Correct.
Yeah. But I'm the special one because I've got PBC.
We know you're special.
Special needs, I think. Anyway, so this one, can you take a TUDCA supplement? This person didn't take enough urso on holiday, it normally takes 1,000 grams a day. Would this be a substitute? I don't know what this is. TUDCA. I don't know.
I think that's a different. That's toro-deoxycholic acid. It's a
Yes.
variant, but we don't have much data on that. There's only been a few small studies. I would not substitute that because I don't know much about it. So they go back to their provider.
Yeah, I think if you're overseas, you're on holiday, you will be able to get her. So I would try and get a hold of it. It's what you know and it's what you need. So again, waiting a full diagnosis, but ALP over the 10 years, 250, 288. What would you expect with PBC? Is this high or low?
It's medium. No.
I knew you were going to say that.
Normal and healthy is less than 115. And I have seen PBC patients with alkaline phos in 700 range. And the level of the alkaline phosphatase crudely is associated with progression, risk of progression, activity of disease. So 250 to 288, they need an AMA, any patient with a high alk phos, but they have to have a GGT done. If the GGT is normal and the alkaline phosphatase is really high, they need to be worked up for another condition called hyperparathyroidism. Has anybody mentioned that on your discussion panel?
Yeah. Is it Hashimoto's?
Oh, it's another hormonal condition that results in a lot of bone turnover. So that's why the alk phos is high, but the GGT is commonly normal. Another question, Collette. Have your team talked about genetic testing?
It's been talked about for many years. You mean genetic testing, like, a family member has it and doing tests on other family members? Is that what you mean by that? Or do you mean the person with PBC having their DNA?
Yeah, that's a great point. So there are researchers like Gideon Hirschfeld and others who have done genetic sequencing to find what genes are associated with PBC. But that's not ready for the clinic. That's a research tool. But there are other conditions that cause cholestasis. Cholestasis means high alkaline phosphatase, high GGT, maybe high bilirubin. So if somebody has high liver enzymes, the AMA is negative, then they maybe get a biopsy. They can't make a diagnosis on the biopsy. Then they need to get a genetic panel performed. And this genetic panel assesses for other conditions that cause cholestasis, of which there's over 80 other diseases.
Wow.
Most of them are quite rare, but I'm working on a paper now. I've got 36 patients. I've screened and only 2 of them were normal. The other 34, we found genetic diseases and explained their liver disease, explained their itching, explained other things. So genetic testing, that's a plan C after a full PBC workup is completed.
That's quite interesting. I'll need to get Robert to come back to you on that, and maybe he knows about it already. I haven't seen him for a bit, but it's very, very interesting, really interesting work, it sounds. But yeah, let's keep that in our sights.
Excellent.
So PBC over 3 years, I'm well controlled with it. Urso, LFT is good. FibroScan 2 years ago, no scarring, fabulous. Last few weeks, issue with gallbladder, but no stones. If gallbladder was removed, would this impact the PBC?
So gallbladder removal affecting PBC, that's a big question. The answer is no. So gallbladder comes out, it's out. You might have some fatty food intolerance, but there's not a direct link. It's not going to make it worse, not going to make it better. Good question. And you mentioned the DEXA scan before, right? Were we on that one?
DEXA scan. Oh, we haven't come to that yet.
Okay, sorry.
No, that's absolutely fine, because that is really important. Because I had a couple of things I was going to say about that. So this person said PBC 17 years, and I don't take Urso. I put a huge big question here. Why? Why? So LFTs consistent abnormal but holding. Disappointing. Having itching and occasional fatigue. I'm 68 and have alopecia, arthritis, and other autoimmune conditions. Am I lucky or should I expect it to get worse? I think whoever you are, you need to get yourself on Urso and don't leave it to the gods. I'd love your comments, Bob, please.
Yeah, holding pattern. I kind of think of that when I'm thinking of an airplane and an airport. So this is a progressive disease in over 90% of people. So this sleeping giant can be moving forward. You need to know, every patient needs to know, provider needs to know stage. And we need to use the correct terms. LFTs, what do you mean? Liver enzymes or liver function?
Yeah.
If the bilirubin starts going up, that's a liver function test. Then things are very late. That bilirubin doesn't start rising until late stage 3 and stage 4. So whenever people are talking about this, we need a lot more detail as providers, and definitely Urso is first line, standard of care to be on Urso. 5% can't tolerate Urso. What are the most common symptoms from Urso, Collette, that you've seen?
Oh, people say nausea and bloating. And I encourage people to start with a small dose and build it up. But, it's non-toxic. It's not a drug. It's a bile salt we already have in our body. We're just taking more of it. And it really is in your best interest if you can try and tolerate it, bear with it. Maybe take it at night time before you go to bed so you don't feel the symptoms as much. Try different ways of taking it. It is important.
Excellent. Totally good. Appropriate points.
Now, so we're coming on to borderline osteoporosis, and this lady would like some advice on supplements, vitamin D, and diet, etc. Before you give me your expert advice, vitamin D should be taken by everybody over the age of 35 in the Northern Hemisphere. We do not have the sunshine, we do not have the weather, and this was in the British Medical Journal maybe 6-7 years ago. We should all be taking vitamin D, and I most certainly do. And I believe that now PBC, it gets tested twice a year at your hospital, or if not, you should. And I would also say to you, and I know you're going to talk about DEXA scans, that if you don't feel that you are getting what you need and there's a diagnosis of early osteoporosis or whatever, you look online at foods. There's foods that can help you as well. It's not that, yes, there's medication, it's really important, but your diet, it's more than milk and yogurt and bread, and bread, does come into it, and cheese, but there's lots and lots of things that can help if you do have this problem. But Bob, I'd like to hear what your thoughts are on this.
Every point you've made is right on mark. And I check vitamin D levels in my patients, and you're right, 90% are low. And what I consider a healthy vitamin D3 level is between 40 and 50. I think it's either milligrams or international units. I have to look it up. So I recheck vitamin D levels twice a year, and I push the vitamin D dose higher and higher to get to 40. And that could be 50,000 units a week of vitamin D2 or 4,000 units a day of vitamin D3. Super important. And then calcium, I found out something very interesting recently. If you take just straight calcium tablets, not much of it's absorbed. So there are new calcium tablets that are mixed with magnesium and zinc. And those are much more bioavailable, bringing more of the calcium into your body. And that calcium dose should be 1,200 milligrams a day, either through food or through supplements. So all this is important. Getting a DEXA scan every 2 years, that's standard of care. But we know from our surveys that the number of people who don't get DEXA scans with PBC is around 60% because they don't ask. And their GI says, oh, that's the primary care. The primary care says, I'm too busy treating hypertension. I forgot, or I don't think it's important. So you as a patient need to be an advocate. DEXA scan every 2 years.
Yeah, proactive. I think ours are 5 years here, but also to help your bones walking. Exercise, some form of, the older we get, we lose muscle mass, but using some weights can help your bones. You can really do a lot to help yourself. Osteoporosis is a very unpleasant condition. I do know now, I have a friend who doesn't have PBC, she has osteoporosis, Bob, but she's now been given injections. She has to inject herself for about a year to try and build up her bone mass. And she said to me, if only she knew that what she ate and what she did could have helped her when she was younger. So it's one of these things where we can help ourselves, which is nice to know. It's good to know.
Yes, that exercise comment is super important, and thank you for that. Vitamin K, we really don't have much research, or B12 to say advice on using either of those. Of course, if you're B12 deficient, you would take B12, and B12 deficiency can happen with an autoimmune condition called pernicious anemia.
Yeah.
That's been seen in PBC patients. So vitamin K, I only use in patients who are in liver failure and can't absorb vitamin K, but that's quite rare.
Can I ask, and here's a good question, pernicious anemia. So it's a vitamin B12 injections, and I think in this country, most of the time, they're giving them their top-ups every 3 months. And apparently people feel a difference immediately that they've taken that vitamin B12. But someone else is telling me where they live that they've been taking smaller doses on a daily basis and they found it far more helpful. Is there a golden rule for B12?
I think it's a great placebo.
A great placebo. Would you like to expand on that, Bob?
It's not going to hurt anybody, but if your B12 level's normal, taking more B12 could help you psychologically, but it's not physiologic. So it's okay.
Okay, we've got a very interesting question here that's come up, and we get asked this quite a lot. Carol, hello Carol, good afternoon. I struggle with my weight. I have tried dieting and cutting down fats, etc. Could I try the injection to help me lose weight? So this is the Ozempic and all the others. We get asked this quite a lot. Bob, what's your thoughts?
So the epidemic of obesity that we see in our world is a mixture of genetics and behavior and bad habits. So everybody could lose weight when they eat less. The problem is eating less is a big challenge for people. They're hungry, they don't feel well, people feel good when they eat. And there's also a bad diet, high in sugars, high in fat as part of the new diet of our people over the last 50 years. So Ozempic and the Ozempic family of injections, of which there's 5 brand names and 2 different types. One's called semaglutide, the other is tirzepatide. Those medicines help people lose weight because they turn off the appetite. They go to the brain and they say, I'm not hungry. And people don't eat. In fact, they feel nauseated or can have constipation, stomach problems. So they are a shortcut. They do work. People can lose 30, 40, 50 pounds on these because they're not eating. The problem is when people stop the Ozempic or the injections, their weight rebounds again because they didn't commit to a lifestyle change, a lifetime of changing what they eat every day, how much they eat and how much they exercise. The problem with Ozempic is it also causes muscle wasting. So you're losing fat and you're losing muscle, a direct effect of the drug. So I have lots of patients who take that. I have them commit to taking it a year or less, and I commit them to psychological support. Psychological meaning they have to treat the stress. Why are they eating in an unhealthy fashion? Why are they eating too much when they know they have heart disease or they can't sleep because of obstructive sleep apnea? But back to PBC, Collette, these medications are safe in the setting of PBC. There's no known bad interaction between the medicines.
Yeah, I think I would add to this. I understand fully. You know, I've not been without weight problems over the years as well, and I've always found diet and exercise, and it is difficult to stick to at some times in our lives, and it is a personal choice whether you take these injections or not. But I just don't see the harm of sitting down and looking at yourself, writing down everything you eat and everything that you drink. And you know, I think we were brought up, you know, just my mother, you know, they were all evacuated during the war and they were still rationing. So we were brought up on 3 solid meals a day. There was no such things as snacks. You know, nobody could afford these things. You know, it was post-war Britain. And I wasn't brought up with them, and I still don't eat them now. You know, I have 3 meals a day or maybe 2. And I just think we should be looking at what we do and why we do it and how much of it's habit. I mean, I know people that have what's called a biscuit cupboard in their kitchen. I thought, why would anybody want a biscuit cupboard? I just couldn't get it. A fruit bowl, I can understand. I don't know, Carol, why it is you've got a weight problem, and it could be none of these reasons, but I just think we should all, and I just look at what I'm taking, what I'm buying, what I'm doing. And I find when I batch cook, as I've been doing today, you know, healthy stuff, get it in the freezer, that, you know, my weight stays really good. Is when I start buying the ready-mades, because, you know, I'm busy, I'm in a rush, I'm stressed, etc. That's when things change, and I don't feel as well. You know, I don't feel as well. And you know, but when I'm cooking, batch cooking, plenty of vegetables, not so much on the fruit, but, you know, I feel better. So have a chat, you know, write things down. You know, if nothing else works, then okay, you know, it's your choice. But I do think we have to self-reflect, Bob, you know.
I agree with a weight loss contract and a weight loss diary. So weight diary is daily weights, calorie counts, exercise. So now I'm having my patients sign a contract with me that they're going to change their behavior. It's on my website. And then I have them turn in a logbook every month. And the ones that are committed to losing weight will write down in a logbook. The ones that are not committed never show me their diary. So, and the key thing, Collette, that I spend time with is what is going on in the background. Is it PTSD? Is it anxiety? Is it stress eating? Is it depression? Is it bipolar? Is it, I really do a deep dive and become a psychiatrist for my patients to figure out what's in the background. Why are they eating unhealthy?
No, that's fabulous to hear you say that, Bob, because I know in the States you do have quite a considerable problem with obesity, and with PBC, it's just, who wants 2 liver diseases? Come on, you know, and the fact that you're not powerless. You can be a bit with PBC. We can't cure ourselves, but goodness me, we can help our livers with what we eat and what we consume and what we do. And I quite like having a bit of power. You know, that doesn't make me feel so helpless as I did in the early days when I was diagnosed with PBC, and there was no treatments, there was nowhere. So I feel quite empowered, and I would urge you also to think about that. But Carol, it's your decision. I hope you find these comments helpful. And we have Inger. How often should I have a FibroScan? I had a stiffness of 5.4 PA 2 years ago. How often for FibroScans, Bob? 2 more questions to go.
So FibroScan is a brand name of a machine made in France, and it is one of 7 different competitors. So I'm going to use a more generic, non-name. So liver stiffness, liver staging every year. And that should be done with a FIB-4 and elastography, whatever machine that people use. And then I like to get ELF tests in many of my patients. Those are the big 3. So staging once a year, imaging like this once a year. That's my recommendation.
Okay. Now, I've got another question about ALP, but it's already been covered, so I'm not going to get back into that. We've covered everything on ALP. It's been actually very, very helpful. So this last question, and this is a really interesting one. So this person says, is it safe to take peppermint oil capsules recommended for IBS at the hepatology clinic? And when Googled, said not to take it with liver disease. Well, you'll find for legal reasons that almost every pharmacy will put that in their boxes. They put on the leaflet, not to be taking the liver disease. It's belt and braces, so it's not to sue them. Is it okay? Should I take when having a flare up? If I may, Bob, and just make a couple of comments here. One is, if this person, if you have this kind of thing, if you tried looking at some of the yogurts and some of the natural yogurts and some of the other things that can feed the gut, good bacteria for the gut, because I know many people who it's changed their lives. The second thing is, now the last time I saw you, Bob, was in London at EASL. And I was on stage with Professor Jones, a lovely Spanish hepatologist, an Italian gastroenterologist, and Andreas, one of our medical advisors. And the gastroenterologist says to me, "What are you doing? What are you taking?" I says, "I'm taking peppermint oil tablets. I get indigestion, but thingy stomach." And she says, No. She says, I'm a gastroenterologist. You do not take caffeine, you do not take alcohol, and you do not take peppermint. So I didn't. And she was right. So that's all I'm saying. Now over to you, Bob.
So the history of peppermint oil is Marco Polo brought peppermint oil back from China.
That's right.
And it was very fashionable in the Italian Venetian days that when you're at a big meal, that when you burped very loudly, it was a compliment to the chef and to the host. And peppermint oil opens up the esophagus. You can have these big eructations, and everybody's just going around burping because of the peppermint oil. But there's no danger to the liver.
No danger to the liver, but do try the yogurt. Please do try it. I don't mean sugared yogurts, with strawberries and all this. Go for the natural things. And they say Greek, not like Greek. The Greek yogurt apparently is very, very good. Great. So, Bob, I think we've done well. We've done a lot. We have 2 minutes to spare. Thank you so much. It's lovely to work with you again, Bob.
Good to see you.
Yeah. So everybody, please keep your questions coming in. I hopefully will see you again soon.